Okay, I get to follow that talk now. Always a challenge following Dr. Moss. So my topic is somewhat related to Dr. Moss's topic, so I'll be covering vertebrogenic pain and clinical characteristics. Now, I acknowledge my colleagues DJ Kennedy and Zach McCormick, who contributed a lot to this talk. So first we'll define vertebrogenic pain. This is a relatively new diagnosis. When April, Bogdach, and Derby did all their work, this concept did not exist. So we'll talk about the pathophysiology and anatomy, and then clinical characteristics that distinguish it from other sources of chronic low back pain, and may improve selection of patients for basivertebral nerve ablation. This diagnosis is somewhat unique for us in that we don't have a diagnostic block or a provocation test to confirm or refute the diagnosis, so we truly are relying on clinical and imaging information. So again, this is a relatively new diagnosis, but it does now have an ICD-10 code, and the description is this diagnosis is used to indicate low back pain that originates from damage to the vertebral end plates. And so this does not include discogenic pain due to disc degeneration or annular fissures or internal disc disruption. And it does not include pain related to vertebral compression fracture. This is related to damage to the vertebral end plates themselves. So as Dr. Moss described, end plate damage occurs very, very early in the degenerative cascade. So end plates are vulnerable to those large forces. He showed how fractures of the end plate can occur. When those happen, we end up with defects or damage with subsequent leakage of pro-inflammatory factors from the nucleus, not just out towards the annulus where there may be some tearing or damage, but also into the vertebral end plate and the vertebrae where you can have chemical sensitization and then nociceptor proliferation. So in patients with chronic low back pain, end plate defects associated with increased nerve concentration have been found when compared with annular fissures. So interesting. This is relatively new to us, this concept. And nociceptors are increased in damaged vertebral end plates. So that's kind of the pathophysiologic basis for vertebrogenic pain. And now MRI and motor changes that Dr. Moss covered. So the motor type 1 or type 2 are both associated with increased likelihood of low back pain. Type 1, again, that indicates edema or inflammation. This is considered an active process. It would be bright on T2, dark on T1 imaging. Type 2, again, fatty marrow replacement due to chronic degenerative process, and this is bright on both T2 and T1. And so these are required when we're making our diagnosis of vertebrogenic pain. Type 3 is not included in this diagnosis, but is associated more with chronic degenerative findings, sclerosis, calcification of the end plate, and subchondral marrow. Interesting study here. In 22 patients who underwent 2-level lumbar fusion, they had motor changes at 1 level and had 1 level without motor changes, and that was the control level. Gene expression profiles of the marrow and disc were assessed by comparing the disc and bone marrow that were sampled during the surgery at levels with the motor changes relative to the control levels. And what they found was in the motic level, bone marrow and adjacent disc, there was upregulation of fibrogenic and pro-inflammatory receptors. So again, more of this basis for the concept of the bone and end plate being a pain generator in itself. So we'll talk about the anatomy as we start to lead towards the procedure to treat this. So the base vertebral nerve transmits nociception from the vertebral body and the end plate. So you can see the nerve here. It arises from the side vertebral nerve and enters the posterior vertebral body along the base vertebral vein through the base vertebral foramen and courses centrally before sprouting peripherally. So it enters through the base vertebral foramen and sprouts peripherally. Okay, and this is an MRI The schematic showing what this would look like. So in the basovertebral foramen centrally, you can see the sinovertebral nerve over here with the basovertebral nerve sprouting peripherally to supply the infants. This is what it looks like on our axial image. Okay, so let's cover clinical characteristics. And this also becomes very important, is this has not really been well defined. Okay, so this would be a typical patient. This is actually someone that I saw recently who went on and had treatment for this condition. 53-year-old patient with chronic axial low back pain. It's worse when he's sitting or bending, so flexion-based pain. Or yesterday we talked about flexion loading those anterior column structures. The pain is worse in the morning. He feels stiff. The pain is midline predominantly, and then does refer to the left all the way into the buttock region. There's no radiation of pain distally in the leg, no numbness or tingling, no leg weakness. Again, findings are not consistent with radiculopathy. And on the MRI, we don't see any significant pathology extending into the canal here, so no significant disc herniation. What we do see here is some brightness on T2 imaging here at the vertebral end plate, and we also see a loss of disc height at that level. So again, in our differential, we're thinking, could this be vertebrogenic pain? Could this be discogenic pain? Both are on the table here. So this is from a study by Dr. McCormick and his group looking at subjects who underwent basovertebral nerve ablation and responded well to it, and using that as a proxy for these patients had vertebrogenic pain using that definition. So patients with chronic axial low back pain, they found that these patients had midline pain predominantly. That was very consistent. The pain was worse with activity in this group and not worse with lumbar extension, so not much there with that. And this doesn't necessarily help us distinguish between discogenic versus vertebrogenic pain. And these patients, again, did have type 1 or type 2 motor changes, which would have been the criteria for them to have this procedure in the first place as well. So again, I think that the main take home here is this midline predominant pain. Okay, so are there differences in chronic low back pain in patients with motor changes versus the usual discogenic pain patient? So this is not from a group of patients who underwent basovertebral nerve ablation. This is from one of our IPSIS members, our European faculty, Heidi Meilenbusch, and her group in the Netherlands. They looked at the typical history of pain associated with motor changes, and we'll go through what they found later, but essentially what they're looking for is patients would have disturbed sleep. When turning around in bed, they would have pain. Their pain is generally constant, but worse in the morning as being as being an important feature. Stiffness, again, this is consistent with that inflammatory pattern of symptoms. Stiffness in the morning, lasting at least 30 minutes. And then adverse reactions to sports or physiotherapy exercises or therapy. And some of the patients did have a history of disc herniation or decompression operations. So these are the findings from her study that she did. So what they found was that of the 51 subjects that they looked at here and came up with a set of clinical prediction rules. Again, they found morning stiffness in 78% of patients. Disturbed sleep was not too consistent. Constant pain, again, not too consistent, about 66% of patients. Federal positive on the level with motor changes, and I'll show that. That was very consistent. So Federal is going to be spring testing over the lumbar spine. Patients who were worse with repeated flexion and had loss of range of motion. So that one wouldn't necessarily distinguish a patient from the discogenic pain patient, which you would also expect to be worse with repetitive flexion. But they also found pain worse on repeated extension with loss of range of motion. And that's generally a group where you would see some improvements in patients with discogenic pain based on prior work that's been done. So Federung is, again, just simply spring testing over that vertebral segments. and reproducing pain with that. They found that to be quite consistent with the level of motor change. This is again repeated flexion and extension and assessing what the response in terms of pain and range of motion is to those movement patterns. So again, both of these in this cohort of patients with motor changes had worsening of pain and loss of range of motion when they went through this type of movement assessment that's done. Okay, and what about episodic pain? So episodic pain is defined as pain that began with severe pain at onset, followed by intermittent disabling periods lasting longer than 2 days. So this is something that when I hear this from patients, especially the younger patients, I certainly think of discogenic pain when I hear patients describe episodic pain. So the question is, does this distinguish between someone who has motor changes versus someone who has discogenic pain? And from Dr. Levin's work, he looked at patients with motor changes, and he found that the diagnostic confidence of episodic pain was only 55%. So while it certainly could occur in patients with motor changes, it's not a strong predictor that would distinguish it from discogenic pain. And this is in contrast to prior work where it is found to be a very strong predictor of positive discograms. So these patients who come in with these severe episodes that happen intermittently are very likely to have positive discography. Okay, so in summary of this, again, with vertebrogenic pain, again, we don't have a diagnostic block or a provocation study that can help to confirm or refute this diagnosis. What we're really relying on is the patients who are responding to the procedure that addresses this condition, which is basivertebral nerve ablation. And so that's where we can really see this. So episodic pain, again, this is common. We may see this in patients with motor changes and who may be responsive to basivertebral nerve ablation, but it has low sensitivity and does not distinguish it from discogenic. There aren't really any physical exam findings that have been validated. So certainly, the work that Dr. Milobush's group has done helps to find out which patients have motor, type 1 or type 2 changes. However, this has not been validated against who responds well to the nerve ablation procedure. MRI findings of motor type 1 and type 2, these are really the key findings, and these are really what's going to probably guide us towards defining someone as having vertebrogenic pain. And this is borne out in the results from basivertebral nerve ablation that I'll cover in a later talk. Inflammatory type symptoms. So this certainly may be a predictor, and from what I see, this does seem to be something that is fairly consistent in this group. So that morning stiffness, the disturbed sleep, that loss of range of motion with movement in both directions. I certainly do see this. Again, this has not been validated based on the data that we have right now. But again, this is a relatively new diagnosis that we have, so I think we still have a lot to learn about how to best define who these patients are and who will respond to basivertebral nerve ablation. So I'm going to stop there. Thank you.